Hello Able clinicians, this is Ali Nasseh with another quick tutorial for you on the topic of indirect pulp caps. Now, all of us know that indirect pulp caps can work if they are done in the correct case and with the right indications. And the right indication usually involves a tooth that is not undergoing irreversible pulpitis. A tooth that has reversible pulpitis, or specifically early reversible pulpitis, usually fares very well with indirect pulp capping. Now, the idea of indirect pulp capping is removal of the decay until you get very close to the pulp. And if you have to leave a tiny bit of decay behind because you would otherwise expose the pulp, in that case, it is okay. What you would end up doing is you would place a medication. In the past, we've used calcium hydroxide medication on these areas, where you place a layer of calcium hydroxide and then you place IRM on top of the tooth, and then you observe and wash the tooth for a while to see how it fares. These bioceramic products are very well suited for the specific indication of indirect pulp caps. Of course, they're also indicated for direct pulp caps. However, in this particular tutorial, I'm going to merely talk about their indirect pulp cap application. Okay folks, let's take a look at the traditional pulp capping procedure and see how the modern materials help us do this process a lot more efficiently and hopefully even more effectively. If a tooth has significant decay, however it is testing with reversible pulpitis, there is a chance that we could still preserve the pulp by doing an indirect pulp cap. And what an indirect pulp cap is, it basically involves removal of the decay. Let's say this is all decay, but it doesn't quite expose the pulp. What we're doing in this case is we're removing the decay in a very, very gentle and effective way without causing damage to the pulp. And what that involves, it involves using sharp burrs, using very gentle strokes, brushing action, lots of water, and basically removing from outside in, not using too much high torque handpieces such as low speed handpieces, but actually your high speed handpiece with lots of water coolant is a key thing in terms of not heating up the pulp. The goal here is to preserve the pulp vitality through not overheating and not causing any damage to these odontoblasts that are lining the dentin. So after doing that, and also another big key is having good isolation, because if you don't have good isolation, and if you're doing a pulp cap, and if you end up having a smear of saliva underneath there, that will certainly not give you the highest success rate possible. One of the reasons why a lot of the direct pulp caps fail is because most of the dentists that are pulp capping at that moment do not have a rubber dam on. So a rubber dam is a significant and important thing to have in these cases. So after removal of the dentin here, without having an exposure, you end up putting your matrix band on to basically give you the final shape. Previously, we were using materials such as Dical or something like that here to line this area that is closest to the pulp chamber. However, we can do a lot better than Dical. Today's material science using bioceramics allows us to provide the same calcium hydroxide that comes from Dical without some of the other materials that are in Dical, which are the resin and all the binders and the fillers and the setting material that makes Dical a lot more cytotoxic than the current bioceramic materials. So what we would end up doing, and one of the things that I do, previously people were using MTA in this particular case, and MTA is a great product. However, the clinical handling and the ability to add some MTA to this area would be a fairly time-consuming process. From a clinical point of view, what I have liked has been the use of the RRM putty material or the RRM syringeable material. This is the Endosequence RRM bioceramic line, and the putty is very hard, like a cavet, and you can actually turn that into a little ball and place it the same way as you did with Dical. But what I found is even more efficiently, I can use the syringeable material, which is the RRM syringeable material, and you can actually use a small little syringeable tip, like a like your acid etch tip, and you can actually put a little dollop of the material directly here, which will very quickly just spread out and cover the dentin. And then the question becomes, what is the right material to restore the space? Well, because the bioceramic is fresh, you certainly can use composite, but one of the things that you could do is you could actually fill the whole space up with glass ionomer. Glass ionomer and bioceramics have a very good relationship and they work well together. So what I found out is I can actually fill up the whole thing with Fuji 9. And you have to be very careful. You just put it at the bottom and gently fill it up so that you end up filling the whole thing up with Fuji 9. Fuji 9 will set fairly quickly, and then you can clear it up, give yourself good contact, make sure you have no flash, and the material sets, and it also bonds well to the bioceramic. Now, for 2 months, I follow up the case and make sure that there are no symptoms and the patient's reversible pulpitis is subsided back to normal pulp. And if everything is good at that point, the tooth needs to be restored now with a final restoration, because Fuji 9 is not a very good final restoration. Glass ionomers tend to leak, especially in a class 2 situation, and they kind of leak ions and they're very soluble. So one of the things that I try to do is I try to send the patient back to the restorative dentist at that point and have them place a composite or an amalgam, and they use the Fuji 9 as the base, and they prepare an ideal prep right into the Fuji 9 and place a composite which will then just cover the margins, and that would be fine, and that will give you a very long-term success rate, provided that you've done a good job during your access preparation preserving the pulp and the vitality of the cells in there.
But is extremely important for NEET and NBDE. So the first question is, why saving pulp is so important? Why not simply remove it and go ahead with endodontic treatment if the caries is quite deep, rather than doing a restoration like composite or amalgam? That's because that permanent teeth takes around 3 to 4 years for root completion, even after the crown has erupted in oral cavity. For example, central incisor in maxillary area erupts at the age of 6 to 7 years, but the root development completes at the age of 10 years. So if the pulp dies or you remove the pulp, there is a condition called as an open apex, or more commonly called as blunderbuss canal, which complicates endodontic treatment. Does that mean that we don't need pulp after root completion? No, pulp is still important even after root completion, because it nourishes the tooth, gives vitality and sensation. So saving the pulp helps us to avoid endodontic treatment, and many times gives us an opportunity to do a conservative treatment like restoration. So before going ahead, let me give you a scenario. You get a patient with deep caries in the mandibular first molar, and the radiograph shows the pulp is not involved. There is around 1 millimeter of dentin between the caries and the pulp. So this case is a deep caries case. So you start removing the caries with a high speed burr and end up exposing the pulp. But in this case, you were sure you had removed all the caries, but the pulp still got exposed. That's due to overcutting. Now this case of pulp exposure is called as mechanical or iatrogenic pulp exposure, which means the pulp is exposed but does not have caries causing organism in it. So this is a healthy exposure. So to manage such situations, we have a procedure called as pulp capping, which has two types in it. First is called as dyed pulp capping, which is used in the case that we discussed of mechanical pulp exposure. So here your material of choice is calcium hydroxide, which is routinely used even today. But now you have a superior material called as MTA, mineral trioxide aggregate. So irrespective of the material, the procedure remains the same. That is, on the exposed pulp, you have to place either calcium hydroxide or MTA and continue with the restoration. Here is what happens now at the microscopic level. As we all know, pulp has cells called as undifferentiated pluripotent stem cells, which has an ability to convert into different types of cell. In above case, because the exposed area of pulp is sealed or capped, by the material calcium hydroxide or MTA, these pluripotent stem cells get stimulated and convert into odontoblast, which are dentine forming cells. So these cells will deposit reparative dentine just below the material where the pulp is capped. And so that's how the pulp closes its chamber, thereby maintaining its vitality. But the success of treatment of that pulp capping depends on multiple factors, which are as follows. 1. You can't make a large exposure and expect the pulp to seal it. The direct pulp capping should only be done if the exposure is 0.5 to 1 mm in size. Second, the exposure should be a mechanical exposure and not a carious exposure. To help you to understand carious exposure, that happens when you expose the pulp in case there wasn't any healthy dentine between the pulp and the carious lesion. That is, caries had reached the pulp, so here the direct pulp capping won't work because the organisms have already reached the pulp and hence the pulp has lost its healthy status and won't repair. Third, patient should be asymptomatic, indicating that the caries has not reached the pulp. Point number 4, on X-ray, you should not see any involvement of pulp or periapical lesion, which routinely happens after caries involvement. The next point is that the pulp exposure should happen in a clean environment. For example, if the rubber dam was applied before caries removal, then the chances of saliva contaminating the exposed pulp is very less, which increases the chances of healing. Another important factor is the hemorrhage, which happens after the exposure of pulp. As we all know, it is the pulp which has the blood supply. So after pulp exposure, there will be bleeding. Now, if the bleeding stops in some time, then the case is considered to be fit for the direct pulp capping. If the bleeding doesn't stop in few minutes, then it indicates that probably the organisms have already reached the pulp and there is excessive inflammation. That's why the bleeding is excessive and not controllable. So in case if there is uncontrolled bleeding, then the case is not fit for direct pulp capping. So my dear students, that was all about direct pulp capping. Now let us go back to the original case scenario where there is a deep caries, but still there is 1 mm of dentine between the carious lesion and the pulp. But this time you don't want to take a chance of doing a mechanical pulp exposure. So in such scenario, you can use the second method of pulp capping, which is termed as indirect pulp capping. So let's know the steps involved in the indirect pulp capping procedure. You started excavating the caries, but this time you remove all the caries from all the walls, but when it comes to the floor of the cavity, you will remove some amount of caries but won't remove all of it, because you may end up exposing the pulp after removal of complete caries. Now that's a mechanical exposure. So what differentiates IPC, that is indirect pulp capping, from DPC, that is direct pulp capping, is that there is no exposure of pulp in indirect pulp capping, unlike direct pulp capping where the pulp is exposed mechanically. So the next step involves placement of calcium hydroxide on the deepest part of the floor and then sealing the tooth with the restoration. Now at a microscopic level, the same undifferentiated pluripotent stem cells will deposit another layer of dentine below the already present thin dentine in the cavity. Now it is a common question that what happens to the little caries on the floor which is left there intentionally to prevent the pulp exposure. For that, one has to know the 3 most important factors for caries formation: the tooth, the organism, and the substrate, which is sugar, most commonly the sucrose. So although in IPC you left the carious lesion which has microorganisms which can still affect the tooth. This does not happen because the cavity is sealed now, and which cuts the substrate, that is the sugar, to the organism, and that's why the organisms will die. Both the DPC and IPC can be carried out in single step or two-step procedure. The advantage of two-step procedure is that it allows you to re-evaluate the pulp status before doing the final restoration. So how do we know whether the IPC and DPC was successful? It's quite simple. If the patient does not develop any clinical signs and symptoms of pulpal involvement, it indicates that the treatment is successful. To be sure, one should take another radiograph after 3 to 4 weeks according to some books, or 3 to 4 months according to some other books. On radiograph, you should not see any signs of pulpal or periapical involvement. One most important sign is the reduction in the size of the pulp chamber in the area of pulp capping because of deposition of reparative dentin. If the signs and symptoms develop, then the pulp capping is considered to be failing and prompt endodontic treatment should be carried out. At this point, I would also like you all to know about another kind of pulp exposure which occurs when there is a trauma to the tooth and the pulp gets exposed. As the exposure here is not due to caries, so it's not a carious exposure and it is termed as the traumatic exposure. So this case can also be treated by diet pulp capping if the patient reports within 24 hours. In the same case, if the exposure, if it is too large, or if the patient reports after 24 hours, then you can still try to save the vitality of the pulp by another procedure called as partial pulpotomy, which is also known as Sweck pulpotomy, or you can carry out another procedure which is called as complete pulpotomy, which we will address in other upcoming videos. So at the end, the important questions which are commonly asked are the difference between the indirect pulp capping and direct pulp capping, which are the materials used in pulp capping, what are the indications for direct pulp capping, how does IPC, DPC work on microscopic level, what are the type of pulp exposures. To conclude, I would like you to know that the procedure explained here is with respect to the permanent teeth and not primary teeth, because in primary teeth the direct pulp capping is contraindicated as it causes internal resorption.